everyone. Thanks for joining us. We are just going to wait another minute or two as people are trickling in. And if you're just joining us, we're just going to wait another minute here and then we'll get started. And we're recording, so if people are late and need to see the beginning again, they can watch it. All right. It's 2 after 12, so we'll get going. My name is Colleen Dell. I'm here at the University of Saskatchewan on Treaty 6 territory and homeland of the Métis. Thank everyone for joining us today for the CRISM Addiction Rounds series. And I want to note that the webinar is being recorded, as I said, and it'll be on the crismprairies.ca website. So you can go on there after and look at it again or share it with your colleagues and so forth, because I'm pretty sure you're going to want to after we hear Kay's talk today. I'm going to open with the CRISM territorial acknowledgement, and I'm going to read that. It says, the Canadian Research Initiative in Substance Matters has members from across all of Turtle Island and the land known as Canada. We acknowledge that Indigenous peoples are the traditional guardians of this land in respect to sovereignty, lands, histories, languages, knowledge systems, and cultures of First Nations, Métis, and Inuit nations. Ongoing criminalization, discrimination, and institutionalization of people who use drugs disproportionately harm Indigenous people. As such, we commit to ensuring this series is anti-racist and anti-colonial and serves as one way to dismantle colonial structures that contribute to ongoing oppression. If you have any questions during this session, can you use the question and answer function? And those will come to myself and then Kay as well, but I'll try to moderate in case there's a lot there for you, Kay, to look at. But you can send your questions at any point during this session, and we hopefully will have the last 15 minutes or so to ask Kay those questions and see her responses. And then I want to remind you at the end, we value your feedback. So complete the series evaluations you're going to get by email. And then also if you want to complete that evaluation, if you want to get credit or a certificate attendance for being here for your records. Okay, all that said, now I want to introduce our speaker, Kay. So Dr. Kay Rittenbach joined the University of Calgary Department of Psychiatry in 2024 with diverse non-academic experience. After earning their PhD in psychiatry from the University of Alberta in 2007, Kay spent several years designing and managing clinical trials to support Health Canada applications for natural health products, and then supported research and implementation of research within the healthcare system as an assistant scientific director of the Addiction and Mental Health Strategic Clinical Network at Alberta Health Services. Kay became an expert on substance use treatment and harm reduction in a healthcare setting and a passionate supporter of the involvement of people with lived-in living experience while in that role. Their 2 years in the Ministry of Mental Health and Addiction provide a strong understanding of policy and government that also influences their current work. They now focus their research on using administrative data and community feedback to help support decision-making to improve the care for marginalized people and populations. Okay, Kay, sounds wonderful. What an amazing background you have. Really excited to listen to your presentation today.
Thank you. I will. We did do a check, so you should be seeing the full screen now, and I'm just going to make sure I can still see this over here. So thank you all for coming. My experience previously, I think, informs my work, but I will say that I have not, I'm just sort of getting into this area of work and I'm really excited about it. So here at the University of Calgary, I'd like to acknowledge and pay tribute to the traditional territories of the peoples of Treaty 7, which include the Blackfoot Confederacy, comprised of the Siksika, the Pekainai, and the Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, which includes the Chiniki, Bearspaw, and Goodstoney First Nations. The city of Calgary is also home to the Métis Nation within Alberta, which includes the Nose Hill Métis District 5 and Elbow Métis District 6. And as an immigrant to this land, I am very proud and happy to be allowed to be here. There we go. My conflicts of interest, I have received a grant from the Calgary Health Foundation that supports the modeling work that I do. I have done my best to use appropriate third-party materials and have my references in the presentation. And I have not used any artificial intelligence for the content or the creation of this presentation or any of the work that I've done that is included in this presentation. So the objectives, I'm going to take some time to explain simulation modeling and cover some about 3 types of modeling, and then give an overview of some system dynamic modeling of the opioid crisis that's in the literature. And then I'll demonstrate some modeling of local relevance to Alberta that with data that I've received recently. So the first question a lot of people have is, what is simulation modeling? Why would you use it? So it's used in a wide variety of ways. You've probably seen it in economics, mathematical modeling. They use it in manufacturing, sometimes to predict like flow of product, and a lot in infectious diseases. So the sort of the kind of models that I'm interested in use real world data to calibrate them, and then can be used to investigate the system. So I think as humans, we inherently try to predict the world in order to understand it or to be safer in it. And so I was trying to come up with some of the simple modeling we do sort of inherently in our life. And I actually had a really hard time coming up with this. And I think it's because it's so baked in that it's hard to see without someone drawing attention to it. So things like the fact that we all expect gas prices to increase for the long weekend is a place where we are we've created a model in our world in our head and predict that that will happen. But the more we try to explain and predict the world, the more we realize how complex the systems we're working with are. And so first, I'm going to acknowledge that the language around this type of work can be pretty vague and doesn't always have clear definitions. You will hear me do that ridiculous thing of defining something using the same words, which makes it very hard to get a firm grasp of the area from the literature. So the modeling itself creates a representation of a system, usually through mathematical models. Logistic regressions are often used. And then the model is used to predict performance. Simulation is then running that model over time and observing how it behaves. And you can change the time period that you can run your simulation for. So it's particularly useful when experimenting on the real world would be impractical or too expensive or unethical. And I think we can all think of parts of the substance use treatment system that fall into that. So there are a lot of types of modeling and there are combinations of modeling. So I'm going to cover some and only really focus on the healthcare applications. So agent-based modeling is probably the type that is most often used in healthcare. In this type of model, the macro rises up from the micro. So an example of this would be modeling individual patients in the emergency room and using that to come up with the wait time predictions. So it really emphasizes individual heterogeneity and localized interactions and the adaptive behaviors that individuals can take. So the figures on this slide are actually from a paper from 2014 that investigated the observed trends in housing for people with severe and persistent mental illness, which is what they defined it as. And it used data collected in the United States from 1950 to 2000. So they created what is on the left there, quite a simplistic flow diagram, which shows that each person comes into the housing decision point, and then there's a set percentage chance to go to each of those types of housing that were identified. And then the variability arose from different responses to the severe and persistent mental illness in each setting. So in some settings, mental health crises result in the individual having to leave the setting. And in some settings, it actually lengthened their length of stay there. So the places where it lengthened their length of stay are also the places that ended up sort of having the population concentrate. And that would be jails and long-term hospitals. But they did include in the paper the restriction that the United States was decreasing the long-term hospital spaces over time. And so the model demonstrated how that shifted more people into the jails. But they didn't create this model just to show where people with severe and persistent mental illness were and why they were in hospital or in jails, but they were trying to investigate the impact of potential changes. And what they demonstrated was that if relapses are delayed, and I believe they chose to investigate increasing the length of time to a relapse by 45 days, then the average length of time to relapse by 45 days, then the model demonstrated that delay would result in people shifting away from jails and into other types of housing. So that information can then be used to support further investment in treatment. So that's sort of the big picture of why you would create a model and what you would do with it. You would use it to support policy changes and be able to demonstrate why you think the desired outcome will happen. It's really important to make sure that both the agent and the activity is well defined. And that sounds really basic, but it can be trickier than it sounds at first. The system dynamic modeling is quite different from agent-based. I think it's really interesting because it can incorporate both quantitative and qualitative models. The quantitative really looks at the real world data. You can also take values from literature or subject matter expertise. And the qualitative side utilizes expert focus groups and documents causal loops and mental models. So you can combine both of these in the same model, use one as a foundation or a starting point, and then add on with the other, or start from the beginning believing that you're going to be combining them both, or use the quantitative part to then support people really thinking about the qualitative part. And I can't highlight enough that those mental models and documenting them is a really big strength of system dynamic modeling. It makes everyone sit down and think through why they believe, why they believe that increasing this will result in this outcome. So it's system dynamic modeling works to document nonlinear behavior of complex systems. You'll create sort of a general representation of a complex system. It tries not to consider single events, and it's often used for long-term strategic modeling. It's the two factors that are almost always incorporated are causal loops and time delays. So causal loop, and I wanted to highlight that one of the first and most famous system dynamic models is actually in sort of the environment. It was in the 70s, and this was the model that predicted that the Earth wouldn't be able to support population as it was growing, and because of resource limitations. And what's important, and the reason I want to highlight that is because what was predicted in the 70s did not come about. So obviously there are limitations to this type of modeling. But causal loops being a defining feature of this type of modeling, they're exactly what they sound like. They're places in the model where the effects loop around. So an example from an infectious disease might be where more people being infectious results in more people exposed, which then results in more people being infectious. And that's an example of a reinforcing causal loop, and it's usually marked on a diagram with a plus sign. Whereas if a quarantine step was added to that loop, so that everyone who's infectious is quarantined, that reduces the number of exposures, and that reduces then the number of infectious people. That would be a balancing causal loop, and it's marked by a minus sign on the diagrams. So this example is from the literature. It's from a 2024 paper, and the title is very descriptive. So they were looking at a qualitative system dynamic model on the overdose bystander behavior in the context of Connecticut's Good Samaritan law, and they used it to identify policy options to increase effective intervention. So they did 5 rounds of group modeling with a variety of experts. And the colors in this particular diagram represent the rounds of the focus groups and what was added with each round. But the last 2 rounds, because each round, the first 3 rounds were different groups of experts, and then the last 2 rounds were combined groups. And the final model got agreement from all of the participants. So they found 4 narratives primarily. Narrative 1 involved overdose, calling 911, and first responder burnout. Narrative 2 included naloxone use, acceptability, and linking patients to services. Narrative 3 included drug arrests, belief in Good Samaritan laws, and community trust in police. And narrative 4 was bystander naloxone use, community participation in harm reduction, and cultural change towards carrying naloxone. So within those 4 narratives, they documented 8 balancing and 7 reinforcing causal loops. And we're going to look at one particular loop a little bit more closely. So this is the kind of diagram that you'll see in literature, which can be a bit much to try to pull apart. So this red loop is part of narrative 1. And it included, I only highlighted these 2 parts of it. So the inner loop documents a connection between people with opioid use disorder experiencing an overdose, the bystander calling 911, the life being saved, which then reduces overdose deaths and increases people with opioid use disorder, which then increases overdoses and starts the cycle again. So this is a reinforcing loop. And again, this is a mental model, a qualitative model. So there is no, this does not have data behind it that shows that these are linked. This is what experts believe is happening. So then the second loop, or panel B, incorporates an impact on first responders. So it documents that responding to more overdoses increases burnout and trauma, which then can lead to worse treatment of the patients, which would then reduce the likelihood of them calling 911. And that makes that loop a balancing loop, where the number of overdoses would decrease because overdose deaths would increase, and there would be fewer people with opioid use disorder. This is just sort of a taste of how complex the qualitative models can get. And what's great is it allows the what if questions to be asked and policy ideas to come out. So I believe in this particular case, they were proposing some interventions to prevent burnout that would be directly beneficial to that balancing loop in panel B. Another type of modeling, and maybe this is a bit of a, it might not be fair to call it a type of modeling, but it's where you see modeling a lot, and it's infectious diseases. They're often called SEIR, SEIR, so susceptible, exposed, infectious, recovered. And they can be system dynamic or agent-based modeling, although there's quite a few advantages of agent-based modeling in this case, because you can then add more the impact of a lot of other things. So COVID's example was that there were some models published that demonstrated the reduction in infections when people were spaced further out. You can also do models in physical, where you can put in like walls and physical spaces and have people sort of run and have, well, the agents run through it on the computer. So I've seen work where you can look at infections being spread in airports and how the actual physical space might cause people to have to be in one space longer, and then that increases the infections. So they can get really complex and be really interesting for understanding the real world. So the final one that I'll touch on is hybrid modeling. And this is more common now, in fact, because computing power has been increasing. So you can combine different types of modeling. Frequently it is agent-based combined with system dynamic. So some of the model can have individual actors, and then others will have the more macro look. And the other piece that is often done is that people will create an agent-based or system dynamic model, but then run Markov modeling on it to validate or determine uncertainty intervals. So Markov modeling is commonly used in economics, and it looks like a decision tree, and you can figure out sort of the likelihood of different outcomes using it. So this will be information that probably all of you are very familiar with, but I wanted to sort of set the stage. Where the toxic drug crisis started in Canada was when they linked it to opioid prescription increases in the early 2000s. And there was a prescription increase, and then there was an increase in deaths related to opioids. But importantly, decreasing prescriptions did not result in fewer deaths. So when I accessed the data in January, there have been over 50,000 apparent opioid toxicity deaths since January of 2016. And there's been a lot of news about this decreased rate and number in 2024. But I think it's important to remember that that decrease is still 17 deaths a day from July 2024 to June of 2025. And so it's still a really significant number, and there is still a lot of work to be done. Here in Alberta, we have publicly available resources on the Alberta Substance Use Surveillance System. And there have been some articles about this system recently, so you may have heard about it. It does provide transparent reporting of quite a bit of data about the toxic drug crisis in Alberta. There's limitations to the site. There are delays in the updates. The death numbers tend to be updated for quite some time because as the medical examiner closes cases, they'll go back and update past months. So it's important to check the date of access when you're looking at the data. And because it began and reports on data from almost a decade ago, we now have different measures and different focus areas that aren't included because we didn't have them back then. So I would suggest that stimulant use is under incorporated into this dashboard. But when it started in 2016, it wasn't really on the radar that it would need to be incorporated. And if you are involved in data, you can probably sympathize with how challenging it would be to change all of the measures that have been reported for so long. So with all of that said, it provides the ability to look at both province-wide data, which is the bottom chart, and Calgary-specific data, which is where I'm located, and that's the top chart. And you can see that that deaths that included opioids increased significantly in 2020, stayed high for several years, and then 2024 there was a decrease in deaths. That decrease was much more noticeable in Calgary than across the province, and it was seen in other jurisdictions. So this decrease inspired a lot of discussion about what caused it or what was driving it, and it's a really challenging thing to determine because there have been quite a few interventions implemented in a variety of ways, in a variety of timelines. And so I wanted to cover some of the different interventions that you might want to consider as causes of the decrease, and just cover sort of what we know about them. So a quick review, I chose these 6. You could probably suggest others, argue for them. But these are commonly discussed and implemented or considered as potential causes. So community naloxone kits. Naloxone is used in medical settings to reverse the effects of opioids. It's a mu receptor antagonist that binds more strongly than other opioids, though it has a shorter half-life. In 2015, the Alberta government provided a one-year grant to the Alberta Community Council on HIV to provide naloxone kits to people at risk of experiencing or witnessing an overdose. And in 2016, this became the Alberta Health Services publicly funded take-home naloxone program. The kits are available free across Alberta from community sites and pharmacies. They used to be available in many emergency rooms, but I don't know if they still are. The first year of publicly reported data, which I got from ACES, shows that just under 6,200 kits were distributed. And in 2024, which was the last full year of data, over 303,000 kits were distributed across Alberta. So you can see the dramatic increase in the number of kits that have been distributed over the years. Opioid agonist treatment is the recommended treatment for opioid use disorder. The medications help prevent withdrawal, and some prevent the ability to experience the high of opioids. There's multiple medications, multiple protocols, and a lot of active research into when they're most effective. So methadone was one of the first, and admittedly, I am not a historian nor a prescriber, so I'm not an expert in this, but it is a daily medication that's usually observed, which can be a barrier to uptake. And so there's been encouragement in Alberta, at least, to move to buprenorphine and to longer acting injectables. But even with treatment, over 60% of the client samples tested in Alberta test positive for other non-treatment drugs, which is also available data available on ACES, and so could be incorporated into various models. Prescription interventions, I feel like, aren't always included on lists of interventions, but they were some of the first to be implemented. So they're designed to decrease opioid prescriptions and make it harder to get long-term prescriptions, because some number of people prescribed opioids go on to develop opioid use disorder. But as noted a moment ago, decreasing prescription rates did not result in fewer deaths. And so some theories are that it actually increases the use of riskier substances. Colleen shared a link in the chat. I just wanted to make sure that it wasn't I didn't miss something. So safer supply is quite political. Most of you have seen articles about it, particularly in British Columbia. The premise is that by providing pharmaceutical alternatives for use, people can make different choices in their life that ultimately are better choices for their stability and society generally. And then because they are known substances, there's not the risk of poisoning from unknown contaminants in the illicit substances. Supervised consumption services have been in the news in the last week or two, and they are also politically controversial. The effectiveness in avoiding overdoses and other healthcare use is well established in literature, and there are places where sterile supplies are available and substance use is observed, allowing for timely and effective responses to poisoning. Recovery communities are another intervention that have received significant investment here in Alberta. They're live-in residential facilities where the focus is on building recovery capital and the involvement of clients in their recovery journeys. The model in Alberta strives for wraparound care and stays of up to 12 months. I have recently seen a diagram of the planned evaluation of Alberta recovery communities that the Centre of Recovery Excellence plans here in Alberta. And I'm hoping that we will have access to that data later and see the long-term impacts of the recovery communities. So these 6 interventions, I don't believe it, well, I shouldn't say this with as much confidence as I am, but I don't believe any of them can easily be investigated with a randomized controlled trial, which is what we're taught the gold standard of causality is. So, and a lot of these interventions are going to be difficult to study in that way and are going to interact with each other in really complex ways, which can make modeling a really useful methodology. So now I will cover some of the current modeling that's being done in this field. I think this model is incredible and really exciting. It's a Harvard Medical School and Massachusetts General Hospital project. It tracks opioid use, misuse, treatment access, and overdose trends. And then it can be used to simulate the impact of different interventions. They've calibrated it to multiple public data sets in the United States, and they use it to support scenario analysis for national level decision making. So they use this model that they've invested a lot of time and energy to create and calibrate as a backbone to investigate the impact of changing policies. So they have some papers out that examine the impact of increasing buprenorphine treatment seeking duration and capacity on opioid overdose fatalities and document the potential impacts of different policies by varying the scenarios. So they varied like how long the policy would take to implement, how long someone kept the policy actively in place, and a few other things like that, and demonstrated the impact throughout the system. So it's called the source model or the simulation of opioid use, response, consequences, and effects. And I, I got to see a couple of people present on it at a conference a couple of years ago, and it's just really amazing what they can do with it. So of interest with that model is that when overdose deaths decreased in 2024, and the decrease was seen across jurisdiction, and there was the discussion around what was going on, the creators of Source published a letter demonstrating that the model, which was calibrated on data up through 2020, had predict a decrease in mortality in 2024. So panel B here shows the source curve and 95% credible intervals, and that's based on 5,000 simulations. The dots are actual data from the sorry. And you can see that the 2024 actual is lower than the simulated prediction, but consider that the model was calibrated on a pre-pandemic data. And these models are not intended to predict an absolute value. They are intended to demonstrate trends and allow you to compare potential outcomes. So the authors discuss and highlight the impact of the years of deaths and that shrank the at-risk population. And the reason that system dynamic modeling helps in this case and being able to tease that out is that the shrinking of the population was hidden by the increase in toxicity overall. This is the author's proposal. The projections were based on Source's pessimistic scenario, which was that there would be full fentanyl replacement of heroin by 2028. And panel A shows the predicted mortality for people with heroin opioid use disorder. And then panel B is for opioid use overdose deaths among the total population. This is an example of system dynamic modeling in Canada, and they were looking at opioid overdose deaths during COVID-19. It's a collaboration between PHAC, the University of Saskatchewan, and the University of Ottawa. It incorporates short-term, long-term prescription use, and the model is on the right, and the paper includes the values that they determined as the probability for each of the letters connecting each of the boxes. So it's a pretty complex model, and they modeled 4 potential futures. And so this is also a demonstration of how they weren't trying to predict the absolute value. They were trying to look at the trends with the different assumptions. So the assumptions, what they modeled were interventions having the same effectiveness. Their interventions included things like naloxone and prescriptions decreasing. And fentanyl percentages remained the same. They modeled interventions having the same effectiveness and fentanyl increasing in the toxic drug supply. Interventions preventing more deaths and fentanyl remaining the same. And then interventions preventing more deaths, but fentanyl increasing. And those are the 4 lines that you can see in 2022. Now, what I would think would also be really interesting would be for them to go back and see what was actually observed during those quarters that their model was predicting. And now I'll get to my work and Alberta data. So I requested supervised consumption service data for all of Alberta, and I will acknowledge that it took about 14 months to get the aggregated data. So here in Alberta, we require a personal health number. I took out the now because I think it's been several years now. But we require a personal health care number to access supervised consumption services, which is very unusual. It's a barrier to access, and historically, harm reduction strives to remove barriers to access to increase uptake. But with the collection of PHNs, we have a unique opportunity to understand the patterns of use and investigate the impacts of changes to those patterns. So when I created an initial model, and I'm creating this model to then go to community and discuss what they see in the model and what they think should be added to the model. So this is an example of where I want to combine quantitative modeling with qualitative modeling. I requested data from Recovery Alberta on the client patterns, specifically on the probability of returning to a site in Alberta the following month. So I'd been hearing for years that there were sort of people who came to the SCS a lot and people who just came sort of once in a while. And so the data is split by the average number of visits in a month. So in the first month, if they sort of they averaged more than a weekly visit, and in full disclosure, without line level data, I do not know if those 5 visits were in the same week or if they were spread out weekly, but they averaged weekly. Where were they likely to be the second month? Did they come back the same amount of time? Did they come back less than weekly? Or did they have any visits at all? And then to look at an outcome for the health system, we also got the rates of emergency department visits for each of those groups in the second month. And then split it by gender. Supervised consumption services is one of the only places in Alberta that collects gender and not sex. So this is gender. So then using software, I've created a model, which is what you're seeing on the right, with the ability to change the probabilities. So created the model with the probabilities based on the data, but those boxes, you can actually put in different values and see the impact on the number of visits in the second month. Well, and by second month, it's 6 months of data so that there's probabilities and distributions, and then the number of emergency department visits that would be predicted. And this is what the actual output looks like. It looks like a graph. The one on your left is looking at the number of visits and is broken down by those who are there weekly and return weekly, those who come in less than weekly, and then the red bars are people who did not return the second month. And then the graph on your right is the number of emergency department visits correlating to the number of returning clients. So this, I believe, was done in months. So that's demonstrating almost 10 years. Well, that's an exaggeration. Let's say 9 years of data simulated. And is representing the baseline. And I should say that the emergency department visits are specifically for opioid poisonings, rather than just all opioid, rather than all emergency department visits. But then using those boxes, I can change the rates. And so I can increase the rate of people who average weekly visits and decrease the rate of new people, or increasing, which are people who were there in the second month, but not in the first. They aren't actually necessarily new people because they may have been there prior to that previous month. Or I can increase that rate of new people and see the impact on the system. And I'm really excited about this. There's still a lot of work to do, but I'm having a lot of fun looking at it. It's very much a starting place. So you'll remember that one of the strengths of system dynamic modeling is the ability to bring together qualitative and quantitative information and simulate change in the system, which will hopefully both be added to this model. So specifically, my next step is to talk with community around what it means if people don't return. Where might they be going? And why might they have more emergency department visits than those who are still visiting the supervised consumption site? We also sort of assume that this higher use group which was, remember, is only one visit a week. So it's an argument whether that's high use, is not only using at the SCS. And so there's got to be some explanation about why they would then have fewer overdoses, even though they are potentially only coming to the SCS once a week. And because I don't know if people would assume that a single visit to the SCS each week would then prevent emergency department visits. So I'm hoping that these conversations will then lead to another focused data request to see other connections to the system. If they're not visiting, are they entering treatment? I've had one suggestion that they may be entering the corrections facility. I also like to highlight that a limitation of this work is that there's no goal for the system. So the data seems to show that maintaining attendance at the SCS lowers emergency departments visits for poisonings, but there's so many better outcome measures. I would not argue that emergency department visits should be our outcome measure. But this was a health administrative data request. I'm modeling the healthcare system, and this is an outcome that is part of health administrative data. So I'm looking at the time, and I think I can open it for questions. So I hope that I've convinced you that simulation modeling has value, and that it will be useful in supporting decision making. So the models have to be created before the decision is needed, because creating and validating the models take time and resources, and to really flesh them out, a lot more community involvement. But once it's created, if you maintain it and update it regularly, it can be a really powerful tool. And that's my hope, is that as I start with this data, build it out, it becomes something that, if there's changes in the service, you can look for changes in the data sort of situation. And I think that the source model in the US demonstrates that, which is one of the reasons I'm pretty excited by it. I do have references for like the naloxone kit effectiveness, opioid agonist therapies, supervised consumption services as sort of reference slides. And I will stop sharing.
Thank you so much, Kate. That was fantastic. You
It's a
absolutely,
whirlwind.
but it's good. And when you get history, which is really important, because if you didn't have that history part, it'd be hard for people to jump into what you're actually doing. It's funny because I was talking with a colleague, he contacted me recently about modeling. He's in mathematics and service dogs and PTSD. And I was fascinated. So some of this actually kind of made sense to me. So thanks a lot for that. It's such important work. And then I love that at the end, you're talking about, and now the community component. So bringing that qualitative component in, right? So that collaboration, and then obviously your focus on supervised consumption services is incredibly timely, right, at this time. So that was a nice example as well. So I am going to open it up to questions. We have about 15 minutes left. If anybody had some questions. I'm going to get started, and it's not,
Right.
maybe it's not 100% specific to this, but I'm really interested in how, could you have done this work if you didn't have your practice-based experience before in Health Canada and so forth? Or could you have come out of academia and jumped into this? It just seems like it's so important to do this work with what you've had. It adds another, you can look at it from so many lenses and angles. And I think that's just so important today as you talk, the whole thing's about systems and their integration and seeing it from all these lenses, right? I don't know if that's a question, but there's something there.
I mean, I think my past experience really informs my interest and my understanding of the data. So I think it can be hard to know what to request or what's available, or to think of how it can be used. And one thing, I mean, I am new to academia, but what I'm always thinking of is sort of, well, can this help support decisions? And I really hope that this can, and in short order. But it is, definitely informed by my experience in the system.
That's great. And what would you suggest? Oh, I have a question here other than my own. So based on what you've been reading on dynamic modeling, do you have a theory as to why drug deaths are so much lower in Calgary in 2025 than Edmonton?
So I mean, my get out of jail free card is that we don't have modeling for Alberta. Um, and a lot of the modeling looks at higher level, so they'll look nationally or provincially. They don't necessarily look city to city. Um, I'm going to call out Elaine Hishka because we were just talking about this, and she reminded me how different the cities are with our populations, with a lot of the influences. And I think that's the most I can say. I think there are probably people in the audience who could answer that if they wanted to. I think they can answer in the Q&A also.
They might be able to, or in the chat. I have both
Yeah.
open. So if anyone has additional insight into that, that would be good. Other
Yeah.
questions? Please just throw them in there.
I was
Is
going to
there
say,
any?
I would also say, I think the difference opens opportunities to try to understand it. Um, but there's always been a wide variety of the rates across Canada, and there's always been a lot of potential explanations for it.
So are there other areas, Kate, where, and I know you gave examples, but where
Yeah.
it's really common for the systems modeling? Like this is just like, we turn to RCTs. Is it a gold standard in another field kind of?
That's a great question. I've really focused my reading on its use in addictions and then opioid, more specifically in the opioid world. But there are groups like I actually saw a presentation on um, they created a whole system dynamic model for their sort of their appointments and their visits,
Oh,
and
okay.
then could play with sliders. So, well, if we have more of this type of visit and fewer of these, then what's the outcome for wait times and what's the impact on all these other places in the system? But that was, I believe it was Veterans Affairs in the US. So they invested a lot of time and had a lot of data to back it up.
Wow.
But it is really common outside of healthcare also. That's just not something I'm
Yeah,
that focused on.
yeah.
Yeah.
What do you suggest for people if oh, we have another question. I missed the beginning of the webinar, but are your hopes to bring this model to provincial policymakers to help advise changes rumored to be coming?
That is, I mean, I really would love if this model became useful and if policymakers were interested in it. I think we all know that not all policy decisions are based on things like academic research. So my hopes are high, but I am not, this is funded by the Calgary Health Foundation and not the government. And there hasn't been a lot of interest in it yet. And I also think that this is a case where I can see both sides because as an academic, I'm supposed to focus on publishing. But decision makers really need the information sooner than the publishing system works. So how do you walk that line also of wanting to support that, but also wanting to make sure that you're um, working for my career?
Yeah. I think you need a CRISM's Prairie Node KT grant to get someone to help you do that, right? So I was going to ask if someone was really interested, because you started from this from scratch in a way, right?
Mhm.
So and it doesn't necessarily need to be an academic, but if people were interested in this, because at the end of the day, I mean, for your policymakers, you have some really strong stories there. And you can tell
Mhm.
it in a story, which I think is really important too, right? So telling your data through a story. What would you suggest? Are there like a key readings or do
Oh,
you go to a webinar or is there a video, a YouTube video where people can start to wrap their head around that? Because it is a lot, right? But
yeah. Ooh. Well, my interest was entirely based off of a paper in seniors care
Oh,
that demonstrated some work that had been done, and then could draw a direct line from the work they did with qualitative modeling. Their problem was transitioning seniors back to home and
okay.
empty and so to open beds, and the policy impact was that they increased funding for respite care and travel costs, because that they realized that through the qualitative modeling and the mental models that were created, they realized that that was part of what was preventing people from being able to shift it back to home, is that their caregivers couldn't get them back for their appointments.
Right.
And that just really struck me, that we always talk about unintended consequences, but that this is a way to try to document them and get to them before they're a problem.
Right.
Um, but that single paper probably isn't that seminal. It just really intrigued me. And then it was talking with Dr. Nate Osgood at the
Yeah,
University of Saskatchewan. Yeah, he's fantastic and really involved in this, and has worked with the Saskatchewan government a lot in modeling, particularly around COVID in the recent years. And so there's just a lot of reaching out and finding opportunities, I think.
that's great. Yeah, Nate, if you haven't been to U of S, you need to come see his office.
Yeah.
Special. Okay, we have one more question here, I think. How does
Mm.
the modeling approach address calibration challenges arising from data collected or reported at different time points?
Ooh. Um, Different models approach it differently. Um, so one, I can tell you that one of the ways I'm approaching it is that I asked for data over 6 months, choosing sort of winter to summer. And then the plan is to ask for another 6 months of data and then compare whether that changed once the model is created. So that's one possible way. There has also been one of the challenges to requesting this data, and one of the reasons that it took 14 months was the pushback kind of from Recovery Alberta, saying that the data wasn't clean enough, and they didn't want to release data that wasn't strong and well sort of good enough data. And so another way of approaching it is to only use data that is sort of that you can reach this sort of pinnacle of accuracy. But that also can really limit what you can look at. So everyone has to make that choice and sort of look at the trade-offs that they're making. So do you want to use all of the data and know that there's a lot of variability in it, or do you want to use only the really clean and accurate data and know that you're losing a lot of opportunities? So there is not one way to approach it.
Okay, we are coming closer to the end, and I don't see any other questions. But Kate,
Yeah.
Kay, sorry, I want to give you an opportunity. Is there something that you didn't touch upon, or is there something you want to just say, clarify something, or whatever? Just give the floor to you to end it up.
Well, I know that these audiences often include community members. And so if there's anyone from Alberta who's really interested in this, I'd be, well, and if you're not from Alberta, I'd be interested in your ideas. But I'd love to, if anyone wanted to reach out and talk more about it here in Alberta, because I am more confident in the models now. I've been focusing on creating that, and I'd really like to start talking about how they can be used and how we can add to them.
Wonderful. Thank you, Kay, for all your work in this and then
Thank
presenting
you.
it in a way that was understandable, I think, for the most part. So we really appreciate that. I want to remind everyone that the webinar recording will be on crismprairies.ca. And then our next webinar will be on April the 15th. And it's in the area of anti-First Nations racism in Alberta emergency departments. So thank you all for joining us. And thanks again, Kay. That was great.